All right, let's do some maternity nursing now. We're going to start with the first trimester, and this is going to be week 1 through week 13. I'm not going to go back any further than that. Anything before the first trimester, you're on your own, okay? Now, let's look at the presumptive signs of pregnancy, like amenorrhea, nausea, vomiting, frequency, breast tenderness. That's when people are presuming that they are pregnant. You've heard somebody say before, oh, they've missed a period or their period's late, that sort of thing. That's what we're talking about with the presumptive signs of pregnancy. Now let's back up and talk about each of these. What is the name of the hormone that elevates in your blood that induces amenorrhea, and it's not HCG? It starts with a P. It's progesterone. Progesterone is what's causing amenorrhea. HCG always sounds right in an OB question, though, doesn't it? But it's wrong here. You see, it's the corpus luteum, which is the small structure that is left over after the follicle has ruptured, that starts secreting progesterone. And so it's the progesterone that induces amenorrhea. Okay? Progesterone is also what makes your temperature go up after you have ovulated. So that would be important to know if you had somebody who was trying to get pregnant and they were keeping their temperature chart. Now, some people keep the temperature chart because they're trying to avoid pregnancy, but more commonly it's used for people to identify when they're ovulating, okay? Because on the temperature chart, when you see a spike in the temperature or an elevation in the temperature, that's when the patient has ovulated. Now, how long is an egg good for once someone has ovulated? All right, that's 24 hours. The egg is good for 24 hours. So, if you were counseling someone who was trying to get pregnant and they were using their temperature chart to identify when they had ovulated, when would you tell that person to begin having sex? Okay, if you're keeping your temperature chart, you wouldn't want to wait until the temperature had gone up, because we don't know, after the temperature's gone up, we don't know how long the egg's been out there. And it's only good for 24 hours. So what you do is they keep the chart for several months, and they learn to anticipate when they think their temperature is going to elevate, and they should begin having intercourse before that time, every other day, not every day, every other day, okay? All right. The next signs and symptoms we have are nausea, vomiting, frequency. And did you know that frequency can be one of the very first signs of pregnancy? Yes, it can, because almost immediately after implantation, what does the uterus start to do? Stretch and grow, pressing on the bladder, causing urinary frequency. And then breast tenderness occurs throughout pregnancy because of all of the excess hormones that the person has in their body. So breast tenderness will occur throughout pregnancy. Now we have the probable signs of pregnancy, okay? A positive pregnancy test, since it's based on the presence of HCG levels. Okay, but you need to know that there are other conditions that can make your HCG levels go up, like hydatidiform mole, molar pregnancy, which we're going to be talking about later in the complications of pregnancy. Also, another sign, Goodell sign, which is softening of the cervix, which occurs about the 2nd month. And Chadwick's sign, which is bluish color of the vaginal mucosa and the cervix, and this is due to vasocongestion. And this occurs about week 4. Also, Hagar's sign is softening of the lower uterine segment, which occurs about the 2nd or 3rd month. Now, y'all, how many times have you heard your friend say, uh-oh, I just had Hagar's sign? Never. You never hear your friend say that. Those are things that the doctor's going to find when I'm talking about Goodell's sign and Chadwick's sign and Hagar's sign, okay? Also, uterine enlargement. Braxton Hicks contractions, which occur throughout pregnancy. They help move blood through the placenta. And pigmentation changes of the skin, like linea nigra. What is that? That's the dark line down the center of the abdomen. The dark line down the center of the abdomen that occurs. And then facial chlasma, known as the mask of pregnancy. The mask of pregnancy. Now, you got to remember something here. The more fair-skinned someone is, the less of these changes they'll have, because that person, if you're fair-skinned, you do not have much pigment in your skin to begin with, okay? Now, and the last thing we have here are the dreaded abdominal striae, better known as stretch marks. Stretch marks. Now, the positive signs are so easy because if you hear the baby's heart beating, it's a pretty positive sign that you're pregnant, right? Right. You can hear it by Doppler at 10 to 12 weeks, 10 to 12 weeks, and fetoscope 17 to 20 weeks. Fetoscope 17 to 20 weeks. Now, fetal movement is also considered to be a positive sign. But when I say fetal movement here, I do not mean the patient telling you they can feel the baby move. I mean the examiner, you, the nurse, feeling the baby move, okay? There's a difference there. Also, ultrasound. Well, that's a really easy one because if they do an ultrasound and see a baby in there, it's a pretty positive sign you're pregnant, right? Positively. All right, now gravidity is the number of times someone has been pregnant. Now, when you're thinking about gravidity, does the duration of the pregnancy have anything to do with it? I said the duration of the pregnancy. No, duration has nothing to do with it. For instance, could you have somebody that was a gravid of 5 and they have no children? Yes, because that just means they've been pregnant 5 times, okay? Maybe they miscarried every time. Now, parity is the number that reached viability. It's the number that reached viability, and 20 weeks is considered to be the age of viability on this test. 20 weeks. Now, you've got to remember something. When a baby is born at 20 weeks, it may be a live birth and it may not be a live birth. When you're getting it, you don't get into that when you're figuring parity. You're just looking at the number of pregnancies that made it to 20 weeks. Some will be live births and some will not be, okay? Now, TPAL is an acronym that gives you further information on parity, and you'll see on your handout what those letters stand for, okay? Nagel's rule. You find the first day of the last menstrual period, you add 7 days, you subtract 3 months and add 1 year. Now, when I say add 1 year, I mean like 2005, 2006, that sort of thing, depending on the time of the year you became pregnant. Now, what this is trying to do is help you identify when the baby's going to arrive, okay? And remember, Nagel's rule is only accurate plus or minus 2 weeks. It is only accurate plus or minus 2 weeks. Now, patient teaching. Well, we always have to start out teaching about nutrition, don't we? Like the 4 food groups, okay? We always go over the 4 food groups first. Calories. They can increase their calories by how many per day after the first trimester? Notice I said after the first trimester. It's not many. 300 calories, okay? And now that's approximately 1 1/4 Snickers bars if you want to get exact, okay? All right, so it's not many calories at all. But if you're an adolescent, they can have more calories. They can increase their calories by 500 after the first trimester. Because, see, in the adolescent, not only do they have to account for the baby's growth, but the adolescent is still growing too. So they can have more calories. Now, increase protein to 60 grams per day. 60 grams per day. Well, here's the deal with that. Normal protein intake for a female should be about 40 to 45 grams. But when somebody is pregnant, don't they have a lot of tissue growth going on in their body? Yes, they have a lot of tissue growth, so they need more protein. Okay? And expect to gain how many pounds in the first trimester? It's not many. 4 pounds is average. 4 pounds is average, okay? Now, I know some people gain weight, a lot more than that, right? And then some people lose weight, too, because they are so sick. That's right. Some people are very sick in that first trimester. Now, vitamin supplements, okay? These days, they say if you're even thinking you might get pregnant, that you need to be on a prenatal vitamin for at least a year ahead of time. Why is that? Because of the folic acid that's in the vitamin. They believe that folic acid is helping prevent what type of defects? Neural tube defects. Neural tube defects like spina bifida. Like spina bifida. Now, As far as folic acid is concerned, we want the patient to get at least 400 micrograms per day. At least 400 micrograms is the recommended dose, okay? Now, a lot of people don't like to take their prenatal vitamin because they can cause GI upset and constipation because of the iron inside of the vitamin, okay? So a lot of times people will try to take them, but they can't because of the GI upset and the constipation. So we need to counsel the patient on this to help them so they'll take the vitamin, all right? Now, the best way to take any form of iron, a lot of times people are just on iron supplements for anemia. The best way to take any form of iron is on an empty stomach for maximum absorption. On an empty stomach for maximum absorption. But how many people can tolerate that? Not many people can tolerate it. So normally we just go ahead and tell them to take it with food. Take with food. But be aware when they take it with food, that's going to decrease the absorption by about 40%. It's going to decrease the absorption of the iron by about 40%. And you know that anytime you're counseling somebody about an iron supplement, the best thing they need to do, or the thing they need to do is take it with vitamin C to enhance absorption. Take with vitamin C to enhance absorption. Now, exercise. No high impact. Walking and swimming are the best exercises, and they do not need to start a heavy program unless they already have been doing so for a period of time. Okay, now if you have somebody who's been exercising a lot, they can continue doing what they're doing, but I don't care how well conditioned an athlete someone is, if they become pregnant, they should not let their heart rate get above 140. They should not let their heart rate get above 140. Now think about that. Anytime your heart rate gets above 140, there is a chance that your cardiac output could do what? Drop. Cardiac output can drop. And you never, ever, ever want to decrease cardiac output in a pregnant person. That can be dangerous because when you decrease cardiac output in a pregnant person, there is a chance that who's not getting blood? The baby. That's right. The baby is not getting blood as it once did. So you shouldn't let your heart rate get above 140. Okay? We also do not want the patient to become overheated during exercise because the increased body temperature can cause birth defects. That's also why they don't like pregnant ladies to get in bath water that's too hot, or hot tubs, or sleep under an electric blanket, because the core temperature of the body can go up so much that it can cause a birth defect. Now let's look at danger signs. Now, most of these danger signs that we see here, if you ever get them at all, will be seen in the third trimester. But we're going to take the time to teach about these things in the first trimester while we have this person in the clinic. Because is there a chance that this might be the only time you ever see that patient? Yes. A lot of times people don't follow up with their prenatal care. Another thing to remember is this. When you get a patient into that first visit to the OBGYN clinic, they're usually excited about the pregnancy, usually, and they're ready to learn. I know your teachers taught you about adult learning theory, and one of the things they taught you with adult learning theory is that people have to be ready to learn. Well, most of the time people are ready to learn right now, so this is a good time to share information. All right, danger signs: sudden gush of vaginal fluid, bleeding, persistent vomiting, severe headache, abdominal pain, increased temp, edema, no fetal movement. Okay? No fetal movement. Now, what if you've got somebody who's been pregnant 4 times, okay, and now they're pregnant with their 5th baby? And they call the OBGYN clinic today, and they say, you know, this baby's not moving as much as my other babies. What my other babies have. What do you think the typical response is that they get from the clinic? Well, the typical answer they get when somebody calls in saying that is, well, all pregnancies are different. All pregnancies are different. But y'all, would that be a good answer to pick on NCLEX? No. even though that's a true statement that all pregnancies are different, they don't want a new nurse saying that because you're brushing off a complaint. You're brushing off a potential problem. And remember, we have to always assume the worst. So we want that person to seek health care is what we want them to do. Okay? We're going to assume that something's going on. Anytime somebody talks about a decrease in fetal movement, we always assume the worst. Okay? Now, the next thing we have are the common discomforts. Now, look at the common discomforts and read over those to yourself or with your friend and see if you start getting in the mood to get pregnant. Okay? I'm going to give you a little bit of time to read those. Are you getting in the mood to get pregnant? Probably not after you read those signs and symptoms. All right, so let's look at this. Sometimes they like to see if you, as a new nurse, know how to alleviate the common discomforts of pregnancy, okay? Because think about it. At the doctor's office or at the labor and delivery unit, who is taking all the patient's questions and phone calls? It's the nurse that's going to be taking those phone calls, all right? Well, look at the person sitting next to you. See them? They're pregnant. I don't care if it's a man sitting by you, they're pregnant. And look at him. He has ankle edema. What are you going to teach him to do about his ankle edema? Elevate, right? Stay off your legs. All right, now he's complaining and calling the OBGYN clinic because he's constipated. What are you going to teach that person to do? All you have to do is go back to the basics, fiber, fluids, walking, okay? Now, let's say they're complaining of nasal congestion, which is very common because when you become pregnant, you have a lot of estrogen in your body, which causes a lot of vasocongestion in your sinuses. That's why you get headaches and that sort of thing. So what can you tell them to do? About the only thing you can recommend is saline nasal spray. Saline nasal spray. You never, ever, ever want to recommend medications because then the NCLEX people are wondering, are they going to recommend medicines to pregnant ladies? So you've got to forget you've been pregnant, all right, and forget what your doctor let you do, okay, because some doctors let you take medicines during pregnancy, not on NCLEX. Now, what are you going to teach the patient about smoking? We want them to stop smoking, of course. And if they still just have to smoke, would you prefer that they smoke inside or outside of the house? We want them to smoke outside so they won't be re-inhaling so much second-hand smoke. You know, smoking is associated with what kind of baby? Small for gestational age, SGA, small for gestational age. All right. Now, how often should a pregnant patient visit the doctor the first 28 weeks? Once a month. Once a month. 28 to 36 weeks? Every 2 weeks or twice a month. Every 2 weeks or twice a month. What about after that? Weekly until delivery. Weekly until delivery. All right, before an ultrasound, what will you ask the patient to do? Now, we're talking about a plain old ultrasound here, abdominal ultrasound. You want them to drink water, to distend the bladder. We want them to drink fluids to distend the bladder. Because when you distend the bladder, that's going to push the uterus up closer to the abdominal surface so we get a better picture. That's right. It's going to push the uterus up closer to the abdominal surface so we can get a better picture. All right. Now, if your patient is having a transvaginal ultrasound, the bladder does not have to be full. With a transvaginal ultrasound, the bladder does not have to be full. Now, what if you were having an ultrasound prior to a procedure? What would you want the patient to do? Prior to a procedure like an amniocentesis, you want them to void, okay? If it's an ultrasound prior to a procedure, you want them to void. All right, now let's look at the second trimester, week 14 through week 26. Now tell me the expected weight gain per week here. 1 pound, no more than 1 pound per week. That's kind of a standard rule that we use throughout pregnancy, okay? So about 4 pounds a month would be the max here. Now, should the patient still be experiencing nausea and vomiting? No, they should not be experiencing nausea and vomiting in the second trimester. Breast tenderness? Yes, we said that was going to occur throughout pregnancy. Now, here's the tricky one. Frequency. You've got to forget you've been pregnant. All right. For this test, the patient does not have frequency in the second trimester. So no is the answer there. Okay? Now let's talk about that. You see, in the first trimester, the uterus is a pelvic organ. It's down low. So it's pressing on the bladder as it grows. But in the second trimester, what will the uterus do? It rises and becomes an abdominal organ, relieving pressure on the bladder. All right? So in the second trimester, no frequency. Now, quickening. What is quickening? Fetal movement. Quickening is fetal movement. And people usually say they can feel this around 16 to 20 weeks. And the more babies you've had, the earlier you can feel that. Okay? Now, what should the fetal heartbeat be during the second trimester? For this test, we're going to learn 120 to 160. 120 to 160. Now, I know your teacher or your textbook may have said 110 to 160. But let me show you the rule that I follow for NCLEX that helps me get more questions right, okay? 120 to 160, we said, was normal. 110 to 120, we're worried and watching. In less than 110, we're going to panic. Less than 110, panic, okay? We're going to really watch that heart rate. They do not want a new nurse to wait until the heart rate gets down around 110 before they start worrying. So they give us the 110 to 120 time to worry and watch and get somebody that knows more than you during that time so we can tell if that's okay or not. See, an experienced labor and delivery nurse won't worry about a heart rate between 110 and 120, but they want us to worry early. Worry ahead of time. All right. Now, the next thing we have are the Kegel exercises. And it's never too early to start these, okay? These are exercises to strengthen the pubococcygeal muscles. And men and women can do these, can't they? Now, after what type of surgery do our male patients do these exercises? After any urinary tract or prostate surgery, they need to do the Kegel exercises, okay? Now, these are the muscles, the pubococcygeal muscles, help stop urine flow when you want it to stop, right? That's why they call it the doorbell exercises. Now, do you know what I mean by the doorbell exercises? Well, here's the deal. If you're using the bathroom and somebody rings the doorbell, you would like to be able to stop using the bathroom so you could go answer the door, right? But if you haven't been doing your Kegel exercises, they're just going to have to wait, aren't they? Because you can't stop things when you want it to stop. Also, these exercises are good for as far as keeping your uterus from falling out, all right, which would be a big problem and very embarrassing, wouldn't it? Yes. Now, third trimester is week 27 through week 40. Now, let me tell you the weight gain per week here. Again, no more than a pound per week. No more than a pound per week. I'm really being extra cautious in the third trimester because, y'all, in the third trimester, aren't there a lot of complications that can occur? Yes, and the weight may be one of those things that indicates a potential complication like PIH, okay? Now, let's say you've got somebody that goes to the doctor in the third trimester and in 1 week they've gained 5 pounds. Okay, well, we're worried. That's just too much. They're going to check their urine for protein. They're going to check their blood pressure. And if all of these assessment data that they're collecting is fine, then they're going to tell the patient, stop eating so much, drink a lot of fluid, and don't eat any more salt, right? Right, okay? But it also could be a sign of a problem, such as pregnancy-induced hypertension or preeclampsia, that sort of thing, beginning to develop. All right? All right, now one more thing I want to mention here is this. Let's say you've got a patient in their third trimester, and their blood pressure is 130/82. Ask the person sitting next to you if that blood pressure is okay or not. Okay, here's your answer. You don't know if it's okay because you don't know what their baseline was to start with, right? You've got to know what their baseline was to start with. Now, I want you to write this down. 30 over 15. 30 over 15. Now, here's what I mean by that. You never want the systolic to be greater than 30 over their baseline, and you never want their diastolic to be more than 15 over their baseline. That's kind of a standard rule of thumb that we use to see if their blood pressure is within normal limits or not. Now, in the third trimester, what should the fetal heart rate be? Again, 120 to 160. 120 to 160. And how is position and presentation determined? What's the name of those maneuvers? Leopold's maneuvers. Leopold's maneuvers. Now, what you're doing with Leopold's maneuvers is you're palpating the mother's abdomen, trying to feel for the baby's head, back, and buttocks. Head, back, and buttocks. Now, tell me something. Why do we care where the fetal back is? Why do we care where the fetal back is? Because this is where you need to listen for the fetal heart rate. It's over the fetal back. That's where you put your Doppler. If you put your Doppler anywhere else, you're probably going to hear the mama's heart rate, which is going to be too low, which would be a sign of fetal distress. So we want to get the baby's heart rate, not the mama's, okay? Now, what should you have your patient do before Leopold's maneuvers? You want your patient to void. That's a comfort measure for one thing, but also if the bladder is distended, your teacher told you that could shift the uterus to one side or the other, and that's not good. We want the uterus in the midline, don't we? Okay? Now, if the patient is having contractions, should these maneuvers be done during or between contractions? Between contractions. Because if you try to feel for the baby during a contraction, are you going to be able to feel the baby? No. You're going to feel a contracting uterus is what you're going to feel. All right. Now, patient teaching. Signs of labor. First of all, lightening usually occurs 2 weeks before term. And this is when the presenting part of the fetus, usually the head, descends into the pelvis. Okay? And the patient will feel less congested, and they'll tell you they can breathe more easily now. But you got to remember, this is going to put more pressure on the bladder, so here comes the urinary frequency again. Now, I don't want you to get lightening and engagement confused. Engagement is when the largest presenting part of the fetus, and again, we hope it's the head, is in the pelvic inlet. All right? So the presenting part is at 0 station. And the baby's getting down in the birth canal, right? That's what we want to happen. Now, fetal stations are measured in centimeters, and it measures the relationship of the presenting part of the fetus to the ischial spines of the mother. So that's on your handout there. You don't have to memorize the picture. I just wanted you to get an idea of what we're talking about by 0 station. And also, I always get the positive and negative mixed up. So you might want to look at that. We're just trying to explain those concepts there in case those words are ever in a test question. You won't be confused by that. Now, we hope the baby's head is well engaged, okay? Because if the baby's head is not well engaged, if the baby is not down in the birth canal good, if you get the rupture of the membranes, if the baby's head is not well engaged, what could come out with the gush of fluid? The cord. And now we've got a prolapsed cord. That's what we don't want to happen. Other signs. Braxton Hicks contractions. Well, they're becoming more frequent and stronger than before. Softening of the cervix. Softening of the cervix. I'll bet your teacher told you that in the non-pregnant female that the cervix feels about like the tip of your nose or a pencil eraser, or sometimes they say like your chin feels, okay? That's the consistency of it in the non-pregnant female. But the closer somebody gets to delivery, the softer it gets. It'll get as soft like as a piece of foam rubber. Just really, really soft. And it starts thinning out too. Bloody show is another sign. Now, in the bloody show, do you expect to see a lot of heavy bleeding? No, but see, that's confusing because they call it bloody show, but we do not want to see a lot of heavy bleeding or bright red blood, because if you see too much blood in the show, we have to assume that our patient is what? Hemorrhaging. Rupture of the membranes and a sudden burst of energy. Now, when you get the sudden burst of energy, what is this called? Nesting. Nesting, like making your nest. They say this is Mother Nature's way of helping you prepare for the baby. All right, and you get a lot of people say they never got the sudden burst of energy, okay? And a lot of people will also say that if you do get the sudden burst of energy, that you're probably going to deliver within the next 24 to 48 hours, all right? And diarrhea is also something the mother might develop prior to delivery. All right. Now, when should the patient go to the hospital? When the contractions are 5 minutes apart or when the membranes rupture. Now, why is it so important that you seek health care after the membranes have ruptured? I bet somebody just said infection. Okay. Well, that's true, but there's something else too that's more acute than that. Prolapse cord. A prolapse cord. See, both answers are correct. Infection and prolapse cord, but the one that's more life-threatening is prolapse cord. Don't get me wrong. We want somebody to seek health care after their membranes have ruptured because we are worried about infection. Because once the membranes rupture, we want them to have delivered within 24 hours because the risk of infection is so high. But the killer answer is going to be prolapse cord. All right? Break time.